Welcome attendees. Just so you know, we'll start the webinar in about a minute. Just giving folks time to transition from the waiting room into the webinar session. So please stand by. We'll start in less than a minute. All right. Good day, everyone. Thank you for joining this webinar, MythBusters, Emergency Medical Services Delivery Expectation versus Reality. We're really glad to have so many people on the webinar today. The session is being recorded, and all of the attendees will get a link to the recording probably tomorrow once it's processed. So you don't have to worry about taking notes, don't have to worry about taking screenshots. Just sit back, relax, be entertained by the wealth of knowledge and information from the folks that we have on the webinar with us today. The chat has been disabled for the webinar, but you can ask questions by using the question and answer double dialogue button that you see on the bottom, or should be on the bottom of your Zoom webinar screen. So as you submit questions, the panelists may respond to your question in writing if they choose to do that, or we will also leave plenty of time at the end of the webinar to take some of your live questions that you've put into the chat. So please feel free to put those questions into the chat as we go. We will not take questions during the webinar, during the actual dialogue, but we will take questions at the end just to help keep the flow going. Chip, why don't you tell us first about AIMHI, and then we'll do some introductions of the panelists and kick it off.
Thank you, Matt. Thank you to all of our participants and to the most distinguished panelists. AIMHI is the Academy of International Mobile Healthcare Integration, represents high-performance emergency medical and mobile healthcare providers. AIMHI members are leading the transformation of EMS to mobile integrated healthcare to improve patient health and experience of care through evidence-based out-of-hospital healthcare system effectiveness and efficiency. And if that aligns with your mission, consider joining us. Thank you.
Thank you, Chip. And did you say most of the distinguished speakers on the panel, or the?
Yeah.
I'm sorry. We're going to try and keep it light. All right. With that, y'all, let's do some quick introductions. Chip, you did the AIMHI overview, but let's go down the line and ask you guys to introduce yourselves to the folks that we have on the webinar.
Okay. I'm Chip Decker. I'm the CEO of the Richmond Ambulance Authority, Richmond, Virginia, and I am the president of AIMHI.
Dr. Kupas.
Hi, everyone. Doug Kupas. I'm an EMS and emergency physician in central Pennsylvania. I'm the medical director of Geisinger Health System's Mobile Integrated Healthcare Program. And I also serve, and I'm listed here with the National Association of EMS Physicians because I'm the president-elect of NAEMSP.
Thank you. Dr. Mackey.
Hi, everybody. My name is Kevin Mackey. I am also an EMS and EM physician. I am here in Sacramento. I work with the Sacramento Fire Department and the Sacramento Airport Fire Department, and I'm a clinician also at Kaiser Permanente, and I'm the Secretary-Treasurer of NAMSP.
Very good. JP.
Good afternoon, everyone. My name is John Peterson. I go by JP. I'm the Executive Director here at Mecklenburg EMS Agency, also known as MEDIC, in Charlotte, North Carolina. I serve as the chair of the Professional Standards Committee with the American Ambulance Association, and I'm also on the board of directors at AIMHI.
Awesome. And then last alphabetically, but certainly not otherwise, Tom.
I was going to say good evening to everyone, but good afternoon to everybody. I'm Tom Wazurek. I'm the director with the Center for Management. We were created by the ICMA about 10 years ago. We spun off into a standalone group, and we work with cities and counties across the United States on dispatch, police, fire, and EMS.
Awesome. Thank you, Tom. All right, let's jump in. Dr. Kupas, let's lead off with you. You've been the primary author of 2 groundbreaking collaborative joint position statements with over 15 national and international EMS and public policy associations, one on reducing lights and siren responses and the other on promoting other EMS performance metrics besides the long-held performance metric of response time. Why was it important for these 2 associations to come together on these 2 hot topics?
Sure, Matt. This is not a new topic necessarily to me. My first publication of a research project related to reducing the use of lights and sirens, primarily for improved safety, was exactly 30 years ago. And, so I've followed this for a long time, but I think that it's only recently that we've seen a true impact of some of what has been done. There have been studies throughout the years, little by little. They've all had little upticks. There are more and more people sort of start to think about what we're doing with emergency responses to everything and that sort of thing. And it was really only a few years ago with a paper that NHTSA commissioned, and then particularly with the first of the 2 papers that you referenced, that there has been just sort of a groundswell of attention paid to this. That first paper had many organizations in it. I used to say that, it was basically a paper of EMS, quality groups, safety groups, and fire, sort of all coming together on the position. I think the exciting part about the one that followed it, the one related to performance measures, is that it was EMS, quality, safety, fire, but then increased with or added with Tom's group. Oops. Sorry, I'm getting a lot of feedback, Matt. I don't know if others are. I just paused to make sure we got that cleaned up. We good?
Yeah, Matt's
Okay.
on here twice.
So with Tom's group joining the second one on performance measures, we now have community leaders, which I think is a really important group to join the 15. And it sort of goes without saying why the original one on lights and sirens was necessary, because the message still hadn't gotten to all the folks that it needed to get to, and full understanding and full utilization. But I think that after we basically had the myth busting of lights and siren, then it's sort of like, well, what do we replace it with? What do communities do when they want to contract for good EMS services and they can't just follow the response times, which clearly is not the best way to ensure that your community is getting quality EMS. So we had to sort of add what do we replace it with? And I think the second one, which alludes to performance measures that communities can adopt to look for when they're putting out RFPs or when they're contracting for quality EMS, this educates communities about what they can use for that.
Absolutely. And, Dr. Kupas, these are organizations that people are seeing on the screen here that, as we often say, don't always agree on the color of the sky, but yet they agreed on some of these issues. Other panel members want to talk about the significance of this coalescence of thought amongst the major associations in the profession.
Matt, I'll take a first whack at this, and I think Doug had referred to this as well. It is, and you did too. It's really rare in today's world to get this many organizations on the same sheet of music. And so I think just the fact that this many organizations are on the same sheet of music and the same paper speaks to volumes about the validity of the words that are contained in the document itself. And I think that as different providers have gone to the way of reducing their use of lights and sirens. We've seen a pretty big uptick in those communities of safety, and reduced injuries, reduced risk, reduced lawsuits. And it just has really, it's really made a massive impact in the country. And in fact, I think this is making its way through the world.
Matt, I know talking to friends in the UK, they were keenly interested in this because they've been advocating this for a number of years, looking at key performance indicators and getting away from just time. And the challenge is, and I put it out for everyone listening here, is educating the news media, who in turn will educate the public. Watching the hurricanes recently, I've screamed at the TV. I feel like the old man telling kids to get off my lawn out front. But there's so much misinformation, and the news media likes to focus on time. I served on the Detroit bankruptcy committee for the governor, and the news media was all about time. Time for police, time for fire, time for EMS. And I said, who cares? And one particular reporter talked, but that's traditionally how we have heard everything, is how much time. And what we know is that probably 80% of the calls to get into police, it's probably 90 to 95. Time doesn't matter. It really doesn't matter for outcomes.
Awesome. Thanks, Tom. All right, Dr. Mackey, let's move to you. There have been a plethora of studies, and you are, like Dr. Kupas, are an avid research wonk. And you've been on a number of these initiatives on the papers. What does and you have this well-earned reputation for being a real thought leader in EMS and certainly in the fire service as well. But what do these studies show in terms of response times, even all ALS? There's a plethora of data. From your perspective as a researcher, as an EM physician, as someone who leads EMS systems, what are you learning, and what should be the thought process for other systems, other communities around the country based on this evidence-based research?
Well, Matt, thank you for that introduction. I've never been called a wonk before, and I'm going to take that to heart. I love that. No, I love that. So you're right. In EMS medicine really started to embrace research heavily at about the turn of the century, about 2000s, early 2000s. And now you see this gigantic uptick of research. Here, we're going to talk about 4 papers just real quickly. And these are some of the older papers, but there are also newer papers, but these all have a common theme. So where did this whole thing with response time start? Well, if you didn't know this, if you're on the webinar and you didn't know this, it really kind of is anchored back to Seattle, to the response to cardiac arrest, when defibrillators were in the hands of paramedics and CPR was in the hands of first responders and EMTs, and the 4-minute time to get someone on scene to begin compressions and the 8-minute time to get defibrillation done. But as we all know, that whole mantra has moved. We have AEDs in Costco, and we have AEDs in our places that we work out, in our gyms. And so the whole mantra of where that all started from has really shifted. So why is it still here is probably the biggest question. And probably most of the people on this call know that it's still here really because it has been anchored into by regulators who need to have contracts with answerable deliverables in those contracts. And then it's also propagated also through the news media, as Tom had mentioned earlier. And so, but here's 4 studies. Let's just kind of real quickly run through these, because there's some really, I find, interesting statements. This first one up here, which is written by Price, actually comes out of the UK. And it was an evaluation. It was a structured interview of 20 paramedics. And get this, the average age of those paramedics ran from 30 to 50. So They're more experienced. Their experience base was 19 years in the system. And the simple question they asked was, does response time standards in your system contribute to your job and the job satisfaction and patient outcomes? I just want to read to you some of the responses from these paramedics. One of them called it ludicrous, an obsession, and impossible. Another one says it interferes with the quality of care and patient outcomes. And a very interesting observation, if you arrive in 7 minutes and the patient dies, that's seen as a success. But if you arrive in 9 minutes and the patient survives, that's seen as a failure. So just this kind of really backwards thinking about that. And then also interesting, in their system, a rapid response vehicle would stop the clock, which is very common in the US-based systems. And so it would de-emphasize and deprioritize a transporting vehicle, which seemed to be a little bit of backwards thinking. And so they felt in this first one that their response time standard of 8 minutes led to higher sick calls, more turnover of paramedics, and adverse impacts on their own mental health. Take it forward, their own Commission on Health Improvement agreed with them and said the response time standards are, quote, too simplistic and narrow. So there's the first paper that kind of takes the first whack at this. And then we're going to look at a pair of these that came out of Denver. This first one looked at one system, one hospital over a year's time. It was a retrospective study. And they looked at basically about a total of 11,000 transports to Denver Health. And they were assigned one of 3 levels based upon low, intermediate, and high risk. And what they found is even with the higher risk patients, if your response time was greater than 4 minutes, it had no influence at all on mortality in these unselected patients, controlling for scene time, transport time, age, gender, and illness severity. Interestingly, though, they did find, and I didn't find the reason for this, that less than 4 minutes seemed to have some sort of positive impact on survival. This paper comes out of 2005. So again, this was kind of early on, and the scope of EMTs was still in its infancy of expanding and allowing them to do these more advanced skills that traditionally been relegated to a paramedic. All right, so on the next one here, it's another study out of Denver, and this one's focused on trauma. And they looked at some other interesting things. They looked at scene times, they looked at ISS, which ISS scores, if you're not familiar with them, are done post hoc after the patient has already been cared for by the trauma service, and a higher number is bad. So they divided them into 3 ISS groups, basically not so bad, kind of bad, and really bad. And they found out that even between those groups, it didn't matter what their ISS was. Their scene times and their response times, less than 8 minutes, did not have a dramatic impact on morbidity or mortality. And then finally, the last one, there's this commentary by 2 luminaries in the world of EMS medicine. This is Dave Cohn and Bob Swore, probably 2 giants in our industry. And they made a commentary on another paper that was in Academic Emergency Medicine. And they said, quote, looking beyond cardiac arrest, there are few clinical conditions that require a rapid response. And there's an EMS outcomes project that looked at this as well in both pediatric and adult populations and found the same thing, except for one thing being cardiac arrest, which was the second least frequent call type that they looked at. But then they point to the problem, and this is the problem. Healthy People 2010 called for response time standards. And so here is the propagation of this continued discussion. It's not by the folks who are doing it. It's not by, I think, in my opinion, the administrators of the EMS systems, the leaders of the organizations like AAA, NEMT, NEMSP. It's really being propagated by the regulators and by, honestly, not totally educated regulators in the federal government, local governments, who need to understand that this response time is not tied to anything that probably really matters to the citizens in our communities. So I hope that gives you a good summary of at least these 4 papers, but there's more out there.
It does. Thanks, Dr. Mackey. And what we'll do for the attendees is in the link for the recording, we'll also include a document that has a plethora of these studies with hyperlinks so that public policy officials, we know there are a bunch of you on this call, and also agency system leaders, these guys are brilliant, and they were picked for this webinar and this panel for a reason, but you don't have to take their word for it. This is evidence-based, peer-reviewed. We need to stop the madness with some of the things that are occurring in our community. And speaking of stopping the madness, let's move to Chip Decker from the Richmond Ambulance Authority. Chip, the Richmond Ambulance Authority just went through a process change to change its response time goals and implement an entire new response system. What were those changes? Why did you do it? And what has been the result?
Thanks, Matt. So the city of Richmond brought in 3 groups of consultants to help us assess the EMS system, everything from the operations to the billing side. And what it ended up doing is giving us a lot of cover to make the changes we needed to make to come up to date, to go with the evidence-based, standards, or what is, what you just heard about with the lights and sirens, reducing that response, changing the response time targets. So, but because the city did it, and I think that whenever you're talking about changing response times, that is a political decision. The politicians need to be on board because their constituents need to be on board. And so everything needs to line up. So what the city wanted, city administration wanted, was basically a cheaper EMS system. And so they basically came back with a whole bunch of ideas like, all right, increase your response time targets, because that allows us to take the resources that we have and use them in a much smarter way. Increase your what you're billing to what the national average is, because Virginia is way behind. So next thing you know, I'm nearly tripling my retail rate. Now, nobody cares because nobody virtually pays that, but there you go. It's out there. And now I got a lot of other localities around us that are, after we took the hit. Now we also, setting expectations, kind of like what this webinar is titled. Now, we sent out letters to all of our facilities, telling them what we were doing, rate change, and whatnot. And to all of our loyal customers, the ones that we see most frequently, because it's going to impact them, especially if they are lower priority folks, that may need non-traditional EMS, if you will, which let's think of, as maybe a home health or just a, come hold a hand call. So we were able to put new rates, new response time targets, and put in a tiered system. That made everybody happy. Reduce the cost of the system, because now I'm not using an all ALS advanced life support system. I'm using chase cars. Paramedics love it. EMTs get to use their skills instead of just, driving a paramedic around. Recruitment and retention have soared. And so overall, everything has worked out really well for us. Nobody's died, because we're able to, to hold the lowest priority calls for a little bit longer, to make sure that I'm not using up all my resources, not running out of resources, or running out of resources as little as possible, whether it's a spike in service, in demand, or if it's, the hospitals are consuming my trucks waiting to drop off patients. Doesn't mean we're getting to the critical calls any slower. They're still critical. It just gives me more opportunity to have resources available to send to those. And interestingly enough, it's much quieter downtown. You know, when you're looking at 100 or 200, you know, calls a day with ambulances running around, fire trucks and whatnot, sirens, that adds stress to the community. And not to mention, it's not healthy for the providers. We all know that citizens have challenges trying to figure out what to do when emergency vehicles are approaching. And so we also embrace the change to have fewer responses with lights and sirens. And the overall impact, not a whole lot. The city's changed in the, you know, the last 10 years. There's now bus lanes, there's bike lanes, it's pedestrian friendly. There's roundabouts, there's humps and bumps and four-way stop signs. And so it's not like we're getting anywhere fast anyhow. And last time I checked, our average response speed around the city was 27 miles an hour running emergency. And so I haven't seen any impact in, you know, in patient outcomes. The data supports what we did. And as I said, it's been a win-win for everybody. And we just embrace the papers you've just previously seen.
Right. So in summary, extended response time, steered system, cooled down the system a little bit, saved some money, less taxpayer support. Quick announcement, public service announcement to those of you that are on the webinar. Rob Lawrence from California has asked if you could please put in your location that you're viewing from, not the room of your house or your office perhaps, but your geographic location. Rob's going to do a quick analysis of the number of people that were on the webinar, where they're from. So in the either in the Q&A or in the chat, I don't think you can do the chat because it's disabled, but in the Q&A, if you could just put a quick note in there about who you are and where you're from, what community you're in, that would be great. Okay, JP, let's move to you. Medic is now on the national and international stage for something that you did related to response times in your community. What did you do? What was the outcome? And what has been the response from the community?
Yeah, thanks, Matt. So really, we wanted to take a look at how we could ensure that we were sending the right resource to the right patient in the right amount of time. And so one of the things we first looked at was our use of lights and sirens within our organization. And what we found is that about 75% of our 911 responses were responded to with red lights and sirens. But only 4% of that 75% resulted in a lights and sirens transport. So just to say that again, we're responding 75% of our calls with our lights and sirens on, but we're actually only transporting to the hospital 4% of that 75%. So there's a big disparity there. And it was an opportunity for us to take a look at how we respond to calls within our community. In addition to that, like many other EMS communities across the country, we've seen a significant rise in our low acuity responses over the last years. And to the point that, as Chip alluded to, that it was dipping into our availability and ability to respond to our sickest patients. So we had to take a look at how we could coordinate all of this work. So what we did is we looked through all 1,800 or so medical priority dispatch determinants. And within those determinants, we looked for potentially life-saving interventions as defined by the National Association of EMS Physicians. And we looked at the percentage of time within each determinant that a potentially life-saving intervention actually occurs. And we were able to use that data to help us determine which calls absolutely needed the fastest lights and sirens response, which calls maybe didn't need lights and sirens response, but still needed an immediate ambulance response. And then other calls that were maybe so low acuity that they could wait upwards of an hour potentially. And that's how we created the matrix that you see on the screen. Our 10 minutes and 59 seconds is our lights and sirens response time requirement with a 90% fractile. Those are our sickest patients, Delta and Echo, if you're familiar with that terminology. And then the 15 minutes is our Charlie responses. These are folks that are sick, require an immediate ambulance response, but not necessarily a lights and sirens response. We know from previous studies that utilization of lights and sirens saves on average maybe 30 seconds to upwards of two minutes. And so it's not that significant of a time. And then our other times there, as you can see, the 30, 60, and 90-minute responses are all non-emergency. One thing I want to point out with our 15-minute non-emergency responses is there is paramedic discretion on those calls. And how that works is a paramedic will read the notes of the call. And if the paramedic sees something that with their clinical education and experience makes them believe that they should upgrade that call to lights and sirens, we allow them to do that. When they do that, we quality assurance review those calls. One, to look and see, is there something that we missed in the initial call intake process that this should have been a lights and sirens call, but wasn't. But also to determine whether the paramedic made the right clinical decision to do that. We're not upgrading calls based on non-clinical reasons. There needs to be a clinical reason why we're upgrading call to go lights and sirens is how we're looking at it. A way that we look to determine to make sure that this is safe was that any call that received a non-emergent response, but ended up with a emergent transport, those calls are quality assurance reviewed in-house and through our medical direction to, one, identify what happened. What happened in this scenario where they got a non-emergency response, but they ended up being a sick patient. That happens about 1% of the time in this EMS system. So very infrequent. And we've been doing this new response configuration for about 1.5 years now, and we have seen 0 negative patient outcomes as a result of response times, especially when looking in the quality assurance reviews of those particular calls. So it has worked extremely well for us, Matt.
So in essence, faster response to the calls that need a faster response, better employee engagement, all that sort of involvement. No one has died, and the community seems to be accepting.
It is. And so, we have seen about a 15% reduction in our ambulance crashes as a result of this change. So it's safer for our folks. It's safe for our community to not be out running lights and sirens to these calls. We did quite a bit of work. There's a couple questions in here, if you don't mind, if I address from the Q&A a little bit about public perception and how is this looked at. And we did a tremendous amount of effort of public education here before we moved forward with any of this. One of the things we did is we met with every city and town council at one of their regular meetings and did a presentation and gave those elected officials an opportunity to ask us questions. We went into each commission district and had public meetings where we had people from the public attend presentation and opportunity to hear directly from us what we're trying to do, why we want to do it, answer any questions. We had a specific website portal where folks could go and learn about what the changes that we're making, but there's an opportunity for public comment and questions. If someone wanted to give us their information, we could reply to them. We did that same opportunity for our first responder partners, who, by the way, and I think really important, we utilized our first responder partners to help us design this from the very, very beginning, both police and fire, all of us together in a room determining how we think we could best respond to our citizens in Mecklenburg County. And so that collaborative effort was very important. We did about, I think it was something like 37 or so media interviews and stories about this to make sure we could get that information out to the public. And then we put QR codes in the ambulances so that if our paramedics or EMTs saw something they had a concern with, or saw something that maybe wasn't going well, they could communicate in real time to us. All of that effort has helped us to tweak this program throughout the last 1.5 years to continue to make it successful. And there's still work being done, of course. When you make major change like this, You're going to find things that maybe didn't go as well as you wanted or whatever, but you have to continue to tweak and work. And overall, we're very satisfied with the performance.
Yeah, and JP, I had the blessing of being in Charlotte at the beginning of the month, and I was there for about a day and a half, and was outside for quite a bit of it. If Jason's still on, we went to some places in the city, and I got to tell you, in 36 hours being in Charlotte, I did not hear a siren. And to Chip's point about being a much quieter and much nicer city, that was really nice. So thank you for doing.
This is Doug, Matt. If I can chime in for just a moment, I think that the public perception thing does need, I want to add to the answers that were just made. First of all, I don't know how many people that are online realize that, Chip and JP are really, two of the most thoughtful communities about how they have approached this and changing their priorities to calls and that sort of thing. And I'm assuming some of the listeners have never even heard about and are probably saying, oh my God, how could I tell somebody that we're expecting a certain group of callers to 911 to get a 60-minute response time. They've done it very thoughtfully and have put a lot of emphasis into public education. There are a lot of people that are in communities where, they're not held to these response time standards because that's not the way their community, contracts for EMS. And, what I will say is that anybody that's running an ambulance agency that doesn't listen and hear the dispatchers frequently say, the callers requested no lights and sirens, et cetera. Our idea of public perception of the lights and siren use comes from us, not from the public. And when NEMSQA did a really wonderful look at 50 communities and how they could change their criteria, I'm in a community that for the last 20 years went from about 20% of our 911 calls being lights and siren responses to now about 10%, and less than 1% with a transport that's lights and sirens. And I think there's good clinical reason to say all that is fine. We didn't actually do any public, and I'm not suggesting that you go that route, but we didn't connect with the public when we made that change. They just, it just became the norm. And I think that what you'll find is that there are more people like NEMSQA found that, the blind community saying, thank heavens, because when they hear a siren in the street in an urban setting, they don't know where it's coming from. They're halfway across the street. They don't know what to do. People in urban settings saying, hey, it is so much more peaceful. Everything we do, sitting outside at a restaurant or something is not, an ambulance coming through every 5 minutes with lights and sirens blaring. So, the public actually, we falsely believe that this is what they want. It's not true.
Matt, if I could give you one more quick just stat. I mentioned at the beginning that at the beginning of this, 75% of our calls were responded with lights and sirens. We now are at 25%. And of that 25%, 9% are transported to the hospital with lights and sirens. So it's a much better ratio.
It is, because now you've got those true critical patients. So yeah, increased specificity as well. So, and you're not stacking bodies like cordwood at county administration, right?
No, sir.
Okay. All right, Tom, welcome from Manila. For those of you that might not be aware, Tom is joining us from the Philippines. So thank you, Tom, for doing that at 1 o'clock in the morning, as you said in your intro. CPSM is the exclusive provider of public safety consulting for ICMA. CPSM does a ton of EMS-related projects. What are some of the primary challenges that you're seeing from these communities? Is there a common theme? And what are these communities asking CPSM through the ICMA to help them with in their community?
I would call it the perfect storm that we're kind of facing right now across most local government. The first thing is either frozen or dwindling funds. Many communities kind of enjoyed the ARPA money for a few years, were able to catch up on some things, in some cases employed people or added services, which with one-time money is not always a good thing. And we're hoping for growth. The biggest challenge I think that we've seen across the country is there are no volunteers anymore. Whether it's to the National Volunteer Fire Chiefs Council or any of the groups, getting people to volunteer anymore is like fighting death's heat. There just aren't the volunteers for a number of reasons. One, they're working more. Two, we're finding it's across the board with employees. When I started in the business in 1979, you wanted to work all the overtime you could so you could buy the toys and maybe play with them someday. Today, the attitude of when we survey workers, they want to buy the toys and they want to play with them today. And so that's a huge change. So yeah, systems that have been relying on overtime to staff or volunteers find themselves in crisis. Now, how do we send an ambulance out? And a number of reports, especially in New York State, they've been trying kind of everything from sheriff department going back to, it's kind of like Back to the Future. But when I started in '79, there were a number of 7 sheriff departments that were putting paramedics on the road. They were trained as paramedic police officers. They've tried that in some New York communities. The challenge is then you start getting your staff really big. And now that burns them because they're going call to call to call to call to call. And what they found out and why they got rid of it in the 70s and 80s, those people burned out. They came to the sheriff chief and just said, you know what? I'm watching everybody else take half the calls I am, and they're going home covered in blood and stressed out and everything else. And they're making the same money as I am. Why should I do this? And so it's kind of like the perfect storm. On top of that, you have low collection rates, or in some cases, in one state, if you're a volunteer agency, you can't bill for service. We all know that EMS has no cost. So that's a really wise decision. So they're trying to change state law that has, never been updated. And so it's all of those kind of factors that we're seeing. And normally we're called in to kind of chart somewhat of a course. Where do we go from here? Can't get volunteers, and we can't hire people. In some cases, we went from the volunteers being scarce. Now we see part paid and employees that we used to kind of maybe employ 10 for 3 full positions. Those people are burdened. So now where do we go? Where should we put our emphasis? And in most cases, they lack the data that we've just heard from all of the systems. The key part, no matter what you're going to do, is having good data. If you as a city manager or you as a elected official are only getting the number of calls for service with none of those other breakdowns, you're already behind the 8 ball because all calls are not equal. We find that it doesn't matter which discipline it is, fire, EMS, dispatch, they're just reporting on calls for service does not recognize the amount of time, the amount of effort, all of the other factors that go in, and whether you're going to get paid for it. In EMS, one of the big drivers is, are you watching the collection rate? Are you if you're a third party, are you staying on top of those? We've seen it in one community that we've been doing for 5 years. It got down to like 10-15% collection rate. And once they got called on the carpet and said that contract may go away, which was a multi-million-dollar contract, they're at about 7% now. It's amazing how that can come back around. But you have to keep an eye on all of those. It's kind of like a juggler. You're keeping your eye on all of the different balls and trying to provide a service. And the biggest challenge we see, EMS in most communities, it's not a charter. It's not a mandated service. And so who's going to provide it? Where does it go? It usually ends up the fire department. Hey, chief, guess what? You're now a fire EMS. And are they equipped to handle that? That sets another whole set of issues. And how do you start burning out your firefighters? If you're a volunteer fire department, you don't want to take EMS on. When I had a combination department, you start making more than 1 to 2 calls a day, and pretty soon you have a spouse angry, and you have a boss angry, and you have a whole bunch of people because you're gone all the time. And so it's a real crisis across the country. And we've seen some states and some areas have declared a state of emergency that they really don't have a service.
Right. All right. Thanks, Tom. All right, let's move back to Dr. Kupas. We've been talking a lot about the response time debunking that myth. Let's talk about this all ALS thing. So, Dr. Kupas, we'll start with you. There's been a focus for years that EMS needs to have a paramedic in every call. What is the current research showing us, and what are some progressive EMS systems doing? I think you're still on mute, Dr. Kupas.
You're muted, Doctor.
That would be better to do that. Yeah, this is certainly of interest to me because I started a few decades ago as an EMT and a paramedic, and with two different agencies, one that was all ALS covering a big county with a significant call volume, and one that was volunteer. And, that was early enough that many places were still calling a paramedic from a neighboring community or a fly car, that sort of thing, to volunteer agencies that had largely all EMT staffing. And, you'd occasionally have the paramedic called. Versus at that same era working with one where it was a paramedic EMT staffing on every ambulance. And, without going into these individual studies, because I know you've got a couple other things you want to cover, and, the bottom line is, this is similar to the 15 plus studies on lights and siren time savings. They virtually all line up saying the same thing. And it's very difficult to find a scientific basis for sending ALS on every 911 response when somebody in the general public thinks they might need medical care. So, the studies do all sort of line up, basically saying that there's not an advantage in general to having all paramedics, and I'm talking about all paramedic staffed ambulances. But then it gets even worse in places where every fire apparatus has to have paramedics on it too, and you have 6, 7 paramedics showing up at some scenes, with no priority saying that they're needed at that. I will take this a little bit to some other examples in medicine. We know in medicine that there is actually good data in many aspects of medicine that show that the experience and how much experience each individual practitioner gets is important. So if you dilute all the intubations in your system out over a large number of paramedics showing up at every call versus ones that get sent just to the high priority calls that might need an advanced airway, those paramedics are not going to be as good at the advanced airway care. And you can apply that to everything else that the paramedics do. We know that from hospitals. There's a reason why every trauma or every hospital is not a high-level trauma center, because there are good studies that show that you have to concentrate the significant trauma at a few centers to have any of them have enough experience with it to get really good and have better results. And that's the same for cardiac surgery. You don't want to go to a surgeon that does a couple a year. You want to go to a surgeon that's doing these a couple every day. So that's what I would say about that, is that it makes sense with the rest of medicine. And the other example that I use all the time is all of this conversation we should apply to, what do you see when you take your patient to the emergency department? Because when somebody walks into the emergency department, we do not have a couple doctors, a couple nurses, a gurney rush to the door to meet every single patient, throw them on there, and rush them to our biggest resuscitation room that is most equipped and has everything, right? Patients know that, oh, you're going to go to the emergency department, you've got a sore throat, you're probably going to be waiting in the waiting room a little bit. I actually do a lecture that says, EMS needs a waiting room. And what JP and Chip are doing, JP's example of the number of priorities they now have, that's sort of the waiting room for EMS. And so if you're responding lights and siren to everything, there are higher priority calls that maybe are getting slower responses because you're not prioritizing them as the highest priority. And those lower priority ones should be in our waiting room. And many of them, as you know, either get signed off at the scene, refuse treatment, there's no patient found, or if they're transported, actually get directed to the waiting room by the folks in the emergency department. So those are examples that we should look to if you're in this mindset of everything needs lights and siren response and transport.
And everything needing ALS. So
And ALS, yeah, absolutely. Yeah, and this is all just applies to the ALS thing also, and more so with the ALS in the idea that that if you're not concentrating the high end things like you do to a level 1 trauma center for high end trauma, or to a paramedic that gets to do lots of intubations a year, then when it's needed, you're probably going to get somebody that's not that proficient at that skill.
Right. All right, Chip, real quick to you. We're going to do a little bit of a lightning round so we can finish on time for folks. AIMHI member agencies are among the highest performing EMS systems in the country. We publish these great benchmark surveys. By the way, sneak peek, part 2 of this benchmark survey will be out tomorrow, so keep an eye on your inbox. In these benchmarking surveys, they reveal a lot about EMS, high performance EMS. What has been the ways that AIMHI systems have been changing and transforming over the last couple of years?
So over the last few years, what we've seen is most all go to a tiered system. Following the data, following the latest, thoughts from all the brain power that's out there to figure out, all right, what works, what doesn't work. So tiered systems, chase cars, and trying to figure out the best way to recruit and retain employees. A study published in the National Library of Medicine last year found nearly 1 in 3 paramedic students were lost from the potential workforce through attrition or failing to certify after completing the course. And so we're, having to address that, get them over the hump, figuring out, all right, what keeps them engaged? Is it, getting them through class all at once, or combining field days and class days? And so basically what the AIMHI folks are doing is we're all just seeing what works, and then sharing that information with, the public, with you all, with each other. And, I take everything JP does and use it.
Yeah.
So, yeah, as I said before, if you're interested in being on the front line of change in EMS, look at our
Look at the
website.
AIMHI benchmark survey. That'll tell you what's going on. All right, JP, lightning round question. What's next for Medic? What's the next big transformation?
Yeah, thanks, Matt. So we've got a lot of project work going on right now, but one of the big things we're looking at, and I don't know how this is going to land or if it's something that we're actually going to end up doing, but one of the things that we're really looking at is how we could potentially send alternate response vehicles to 911 calls for low acuity calls, right? In this system, we have about 40 to 45,000 calls a year that don't result in a transport. Yet we're sending an ambulance to every single one of those calls. So that's a huge number of calls that if we could send an alternative resource with obviously well-trained personnel and something other than an ambulance to help determine, what help those folks need or what assistance to get them the help that they need. That's something that we're seriously considering. We don't currently have a community paramedic service in this service. But this is kind of the way that we're looking at doing it right now.
Awesome. Thanks, JP. Dr. Mackey, again, great pictures of you here, by the way. I saw this great media story about something that you guys are doing, but it's often been said that most EMS systems weren't designed, they evolved. As a board certified EMS physician and a paramedic, whose son is also a paramedic, if you were to design an EMS system for community X, because they don't have one, you're going to design one, what would be some of the key elements? What would you do?
I'd have to understand my community's needs, first of all, and there has to be discussion about reimbursement as well, which is a whole different webinar in itself. So I won't get into that. But after you understand your community's needs, there are opportunities that are coming down the pipes as far as things like micro-credentials. So let me just get into that just for a second. These are EMS clinicians that have been credentialed to do things that are typically outside what you'd typically get trained at a paramedic school or an EMT school. So doing expanded scope. But this is a multifaceted approach in your community. I want to give you a good example of one that's very successful, if I could. And it's not mine. I get to borrow from a friend. So Fire Chief Bruce Evans, many of us on this call know him, Upper Pine River Fire Protection District, is beginning to build intentionally clinics into every single fire station that he builds. And the reason for that is because he understands in his local community, access to care is the greatest challenge. And so if he can build in clinics and staff those clinics with advanced practice providers, the community gets their needs addressed. And so if I'm going to build the system, I'm going to try to understand my community's needs, and I'm going to try to answer those needs with innovative ways, with either expanding the scope of my clinicians and or building in access to care in non-traditional ways.
Awesome. Tom, for you, from a public policy perspective, and you see these projects all over the country, all over the world, really, how would you design the system if you were building it from scratch?
I would do exactly what Dr. Mackey. Matter of fact, 12 years ago, I think we worked with Bald Head Island, North Carolina. Their big problem was anytime they transported a patient, they had to go on a ferry boat across the mainland. So they lost their staff. What we worked with them on, they ended up bringing a physician's assistant at their fire station. They could do jellyfish stings, they could do stitches right on the island, and they didn't have to send people off unless it was serious. And then for the extremely serious, they entered into a contract for helicopter transporting the most serious. But the majority of their calls, they never had to leave the island after they made the change. So it's knowing your patients, knowing where it is, looking at alternatives, sending out an ambulance, fire truck, battalion chief, everybody else is expensive. The liability is immense. And I point out to cities, smash one of those, going to a call. You're 2 to 3 years. I was just talking to this equipment manufacturer. It can be 2 to 3 years before you're going to get a replacement. And the expense is huge. Not to mention you'll have and everything else. So all of those things, if I were going to design a system, I'd start from scratch and start from a point of success. And I think we kind of created some of this going back, and we've all talked about it, public perception. Anybody ever watch Me TV at night? Just before I go to bed, I click it on. Rescue 51. One of the calls the other night, my mind just blew. They sent Squad 51, Engine 51, and a ladder company to a lady that stuck her toe in the bathtub. And I thought, wow, what did we do? And I think we created that aura that this is what you're going to get, and you don't need it. I mean, they put I think they put gasoline in her toe and rain. I mean, it was, but that's where we really got to bring that public education. All of those components have to be in play.
But Tom, that's an extrication call, right? So they didn't send it.
I was waiting for him to rip it off the wall, bring in the jaws and just tear the bathroom apart. But it was, I looked at that and my mind just blew that we actually thought that was a good idea back in the 70s.
Yeah, well, a lot of things were different back in the 70s, right? So, all right, so I got a couple of announcements. First, before I thank our panelists. So we just got confirmation that we are able to download the questions. So we're only going to be able to take really 1 or 2 questions. We're going to download the questions that people asked, and we're going to ask very nicely the panelists if they would help with a written response that we will post probably next week, summarizing the answers to probably the most common questions that came through. That would be great. So for the panelists, be on the lookout for that. There was a question in the chat, I think that was for Chip. Were you able to do that, Chip? I'm looking through all of the things that people did for Rob Lawrence about where they're from, but I'm looking for any open questions.
There's one from Dan.
And
Fire
there's,
away.
and there's one from Carl. Yeah.
You guys pick one. Pick one and fire an answer.
So, yeah, Dan asked, when I said no one died, what were my matrix? So let me reframe this for Dan. We still have fire first response. And so I guess anecdotally, I haven't had the fire department tell me, oh gee whiz, the 2 minutes you added to priority one calls, you know, if you'd been here 2 minutes earlier, that the patient would have survived. You know, we haven't had, when I say no one has died, it's just a matter of, yeah, no one, we still have the other components that are part of the system. And so, yeah.
Dr. Kupis?
So Matt, one thing that I would say about that in regards to that answer is there was another question that came through that I typed the answer to, and it's not on the screen anymore. It's under the answered ones, but it was about first responders. And you know, my point to that is that some places retain first responders. Other places, my system uses very little first responders. Does lots of non-lights and siren response, but you know, it's not a necessity to retain the first responders. I think you have to look at your system, but in many systems, those lower priority calls probably should be done without first responders, because I think that, you know, you can also protect and retain your first responders and have them burn out less by using them less, not to mention the incredible savings to a community where they are, you know, ramping up pay and people to keep a bunch of first responders to go on every call, you know, for some that are a toe stuck in the water pipe.
Well, and if your goal is to get to the 1% of the call volume that needs a 5-minute response, the ambulance is the least efficient way to do that. Your first response program is the best way to do that. So measure the metrics for the first response arrival, keep them available.
Yep, protect your first responders just like you're protecting your ambulance crews with this, from both being in crashes as well as you know, as well as the necessity for priority calls.
Right, keep them available. So, any closing comments from our esteemed panelists?
There was one other question in here, but I can't answer it. It's about fly cars, rapid response cars, and what the ratio is. We don't use them currently in our system. Anecdotally, I would imagine it would decrease cost, but I can't answer that question. Sorry about that. I didn't know if anyone else.
Before Chip unmutes, when we did it at MedStar, we went from all ALS to tiered. The ratio was about 6-to-1. So for every 6 BLS units, we would have an ALS fly car available. That could be a supervisor, could be a community paramedic, could be a critical care paramedic. So that was about the ratio. And even when the fly car was either presumptively dispatched on the call, or and that's really when it happened, if there was a Delta or an Echo level call, they sent a BLS unit and they sent the chase car, 99 times out of 100, the crew canceled the chase car. Because the call sounded like it needed ALS, but as you all know, if you're providers, they typically don't. So they would get canceled typically. So big cost savings and tremendous increase in resources on the street. So better for everybody. Thank you, gentlemen, for investing the time, energy, and effort to do this with us. I did get the questions, so we'll do some follow-up. Your time has been exceptionally valuable, and hopefully the folks that have been on the webinar and folks that will watch it, which is going to be multiples of the folks that were on it, will derive from value for this. So keep an eye out for the recording link and for the Q&A to come out in the next week or so, the answers to those. And thank you all for attending. Have a great rest of the day. Gentlemen, thank you. I'll follow up by email to the group.
Sounds good. Thanks, Matt.
Tom, good luck in Manila. Have fun at the wedding.
Thanks so much, Matt. Have a good day.
Take care,
Bye.
everybody.